Bonjour à toutes et tous. Bienvenue à la série de conférences de Montréal en éthique de la santé. Je me nomme Éric Racine. Je suis directeur de l'unité de recherche en éthique pragmatique de la santé à l'IRCM, professeur à l'Université de Montréal, l'Université McGill. Et les travaux de l'équipe que je dirige visent à développer des approches co-créatives en éthique et favoriser le dialogue public sur les questions d'éthique. So for those joining us who are English speakers, I will come back to you in a few minutes. I'm going to do a little bit of a recap of the former lectures we had this year already, and I will introduce Dr. Foster in just a minute. Comme vous le savez, la série de conférences de cette année porte sur la thématique de la santé et du bien-être des femmes. C'est une thématique qui s'est imposée pour son importance historique, mais aussi étant donné l'actualité que nous vivons localement et internationalement. Donc, on va tout au long de cette série aborder une série d'enjeux importants liés à la santé et au bien-être des femmes. Déjà, le 6 février, Léa Clermont-Dion est venue présenter une conférence qui était magnifique, mais sur un contenu un peu, comment je pourrais dire, préoccupant, troublant, sur la montée des mouvements anti-avortement au Canada. Et le 20 février, Maître Lydia Assayag a exploré les inégalités entre les hommes et les femmes ainsi les tensions que ça pose dans le cadre de la médecine conventionnelle. On vous l'a expliqué, on prend un moment pour le réexpliquer, mais cette année, on vise à favoriser la délibération publique et donc il y a un sondage, vous trouvez le lien dans le chat en ce moment, qui vous permet de participer à une réflexion sur des pistes de recherche et d'action qui concernent la santé des femmes, santé et bien-être des femmes de manière très large, en lien avec les conférences qui sont abordées. Donc, c'est un formulaire qui est très simple à compléter et vous pouvez le compléter après la conférence à votre guise. Aujourd'hui, on revient sur le sujet des droits reproductifs des femmes et de l'avortement avec Dr. Diana Foster, que je vais introduire en anglais. So, Dr. Foster is a demographer and professor at UCSF, the University of California at San Francisco. She has led a very famous study, the Turnaway study, which is an American nationwide longitudinal prospective study of the health and well-being of women who have received or have been denied abortions, wanted abortions. She is a leading scholar of the health and legal and economic consequences in these areas, including the end of Roe, and is carrying a Turnaway study in Nepal also. She was named a 2023 MacArthur Fellow, and she's the author of over 100, even 120 academic papers, and has a book published in 2020 called The Turnaway Study, 10 Years, 1,000 Women and the Consequences of Having or Being Denied an Abortion. The title of our talk today is Consequences of the End of Roe, Lessons from the Turnaway Study. The study has already been mentioned by a number of lecturers already, so we're really privileged to have her with us today. She will discuss the consequences of the end of the federally protected right to abortion in the US. She will describe the options open to those who want an abortion and live in one of the amazingly 21 states that have severely restricted or banned abortions. And we'll talk also about related consequences and trends in travel, telemedicine, self-managed abortion, which is something my grandmother talked about, and she was born in 1905. So these worrying trends will be the object of the discussion. And she will talk about the consequences of carrying unwanted pregnancies to term. This is something that was not so well documented, and the Turnaway study has examined the health, economic, and life course of receiving versus being denied a wanted abortion. So thank you so much for being with us, Dr. Foster, and we look forward to listening to you today.
Thank you so much, Professor Racine. It's really great for me to be here participating in anything with Canadians, given that my government has made it feel so hostile between our countries, but know that the individuals do not agree with the tensions that are rising. So I'm here to talk about the consequences of receiving or being denied an abortion. Someone will tell me if it doesn't look right, the screen, I hope.
It's
Uh,
perfect.
Great. So as you may know, um, the June 2022 was the Supreme Court, our US Supreme Court, made a ruling about a ban on abortion at 15 weeks. And when they agreed to hear the case, maybe a year before that, we knew that Roe was on the line because there was no reason to even hear that case if they weren't considering banning abortion or severely limiting it. And when they made this decision, they ended 50 years, almost 50 years of federal protections for abortion, which meant that every state could ban abortion as they see fit. And indeed, many did. So 22 states have abortion bans that would have been unconstitutional under Roe, and 79 million people live in states that have total bans. So that's a quarter of the US population. Another 13% live in states with 6-week bans, which can be very hard to realize you're pregnant and decide on an abortion and go get one all within about 2 weeks from the time you miss your period or may have missed your period. Another 10% of people live in states that have limited after the 6 weeks, but before viability. And what we know is that in 2020, which wasn't a typical year because of the pandemic, but approximately 100,000 or so abortions happened in those states. So there's probably 100, more than 100,000 abortions that or unwanted pregnancies in those states. And the question is, what's happening? So here are the states, and where they are, you can see that they're concentrated in the southeastern United States. And so here are the options for someone who's pregnant and doesn't want to be, but lives in a state with a ban. One, they can travel to a state where abortion is still legal. And from that map, you can see that could be quite a distance. They can obtain medication abortions through telehealth, and I'll talk about what that is. They can attempt to end the pregnancy on their own, so self-managed abortion, as our grandmothers probably didn't use that term, but definitely knew all about it, and carry the pregnancy to term. And this is where my expertise is strongest. So first, traveling to a state where it remains legal, even before even before the Dobbs decision, people had to travel long distances. But now about a third of women live more than an hour from an abortion facility, which is, up from 15% before Dobbs. And we know because access to abortion was very uneven under Roe, that when you make people travel a long distance, it slows them down, it raises costs, and many people can't get abortions when they have to travel. And there are certain groups of people for whom travel is particularly difficult. For example, people who are later in pregnancy, because the procedure can take many days, and so they have to stay where they have to stay near the clinic for multiple days. There are very few places that do abortions later in pregnancy, so they have to travel farther. Also, people without the money or resources to travel, minors, so people under age 18 are probably particularly difficult mustering all the resources that's needed to get travel. Undocumented immigrants now have particularly high have to have a really high risk tolerance to try and cross state lines. People with disabilities, incarcerated and hospitalized, all maybe have physical difficulties traveling. But yet, despite that, we know that a lot of people traveled. So 1 in 10 crossed state lines in 2020, 1 in 5 cross state lines after the end of Roe. And the states with the greatest increases in formal sector abortions, so getting abortions from clinics and clinicians, are Illinois, California, and Florida. And the fraction of people, what we know from a study that we've led at UCSF is that all of this travel slowed people down substantially. And the fraction of people who had a second trimester abortion increased from 8% of all abortions to 17%. So this is very likely slowing people down. Another option is they can try and get abortion pills by mail. The two drugs, mifepristone and misoprostol, are approved through 10 weeks of pregnancy. They're very effective at ending a pregnancy without need for aspiration later. So 95 to 97% are complete with medications alone. Serious adverse events are rare, but not zero. And there's some risk to mifepristone. So the question of if misoprostol is more accessible worldwide, and many countries, people go to the pharmacy and say their grandmother has an ulcer and get misoprostol for that ulcer and then take it to end a pregnancy. And this regimen is less well studied in the United States, but it could be anywhere between 80 to 100% effective. And it's very, effectiveness is tricky to measure because what is the cutoff? How, I think that if you keep taking misoprostol, eventually you'll pass the pregnancy, but there should be some definition of how long that should take. There's clearly a massive increase in utilization of medications to end pregnancies. It was just about a third in 2014, up to half just before the Dobbs decision, and up to 63% of abortions, formal sector abortions in the United States, in the most recent year that we have data available. So the reason for this increase in medication abortion is partly due to the COVID pandemic. And during the COVID pandemic, our Food and Drug Administration removed in-person requirements for dispensing medication abortion. And so now patients were able to get abortion pills in the mail. And this is a massive improvement in access because the combination of restrictions, it could be that you would have had to travel 100 miles to go to a clinic, then have hear some kind of counseling, wait 24 hours there, go back, get the pills, and then go home. And that instead, you're just receiving them at your mailbox. So this is a dramatic improvement in access for lots of people. And we see that, that had already been the trend before Dobbs. It isn't necessarily due to Dobbs, but it is due to Dobbs because people are not able to get abortions in their own state, so they can get them from telehealth. And just a little study from Upadhyay and all on the effectiveness and safety of telehealth. So the question is, if you don't get the pills from a provider, are they as safe and effective if you get them in the mail after potentially being screened by a provider? Does that hurt the safety and efficacy? And the evidence is that it does not. So yeah, when we look at the comparing, in fact, directly no test telehealth, so you never went in and saw a provider, you never got that ultrasound, and so you either mailed the pills or you went and just picked them up from the clinic. How does that compare to an in-person visit with ultrasound? And there's no difference in effectiveness or safety. So continuing on this medication abortion pills by mail, the way that this has happened is that states with protected access, so we're red and blue, we're highly divided in the United States, states that restrict access to abortion and states that have loosened their laws and removed extraneous restrictions. So there have been laws passed in protected access states that allow prescribers to prescribe to people outside of their state. And these are the states that have enacted bills that protect abortion pill providers, so physicians and nurses, and nurse practitioners and physicians' assistants to prescribe these pills. So just looking at the trends, the blue is, this is the trends in telehealth. So at around 2023, this line more marks when we were able to actually collect the data on what was going on. But what we've seen is a massive increase in telehealth. Where abortions provided under shield laws is in the lightest color. Abortions, actual abortion facilities are not just serving patients who show up at the door, but also sending pills in the mail. And then there are organizations like Aid Access, which are only virtual. There is no brick and mortar place for you to show up. And that has also increased over time. This is all post-Dobbs, so you can't, the line is not Dobbs. The line is when we were able to actually measure the change. So just looking at two states, what we see is that the blue is obtained in state, the dark blue, and clearly looking before and after Dobbs, the in-state provision went away, but and there was always travel out of state, so that's the lighter blue color. Post-Dobbs, instead of in-state and travel, what you see is increased travel and then increased provision through of medication abortion under shield laws. And this only counts, these graphs are only formal sector abortions. This is not people self-managing their abortion. You can see that we're almost up to the same level of abortion, formal sector abortions in Texas, and we've even exceeded it in Mississippi. So what are the barriers? Why does this not work for everyone? One is that not everyone knows you can order pills by mail. There are two amazing websites that I know of that will ask you where you're living and how far along you are, and will tell you what your options are. Those are plancpills.org and ineedana.com. But to order pills online, you need a computer, a smartphone, a mailing address, and maybe a credit card. So not everybody has these. Most states that ban abortion also ban telehealth, you'd be surprised to know. And there's always a risk that pills wouldn't arrive or could be intercepted, although we haven't seen much evidence of that yet. And, this asks people to do their abortions on their own pretty much. And they might want more advice and interaction about what to expect. There's also a hotline for that, the M&A hotline, so miscarriage and abortion hotline, staffed by physicians, so that if you're experiencing a complication, you can find out, is that a serious complication or an expected side effect? And then there's also the fear of legal risk. So all of a sudden people are ordering pills online when it may not be, when it's questioned whether it's legal or not legal. And there's another hotline for that, you'll be happy to know, that actually can give people legal advice. But the biggest concern about legal risk is that someone will need medical care and will be too scared to get it because they're worried about getting in trouble from having taken pills on their own. So this leads us to the third option, self-manage an abortion. And here the distinction between ordering pills through telehealth and taking them on your own, I'm not calling that self-managed because that is, there's at least a clinician screening you and someplace you know to call. This is people getting abortion pills without any interaction with a clinician or doing something else to end their pregnancy. And we know that this was common even before Dobbs. So 7% of US women reported to us that a lifetime history of trying to end their own pregnancy. When we studied this before the Dobbs decision, only a quarter were successful and 11% of them needed medical treatment to deal with complications of what they've done. The most common things that people do are herbs, misoprostol and mifepristone, that they've secured outside of a formal medical system. So that can be ordering from online vendors or getting it at the local, what's it called? Swap meet, the local, this is another word, and I'm sure swap meet is not taught in as a common English word, but anyway, so they've gotten this kind of black market. Other drugs, so using high levels of alcohol or other recreational drugs, hoping that it will end the pregnancy, and then physical methods like hitting themselves in the abdomen. When we redid this study just a few years later, the percentage of people reporting a lifetime history had gone up a lot, which is concerning because it wasn't that many years difference in these estimates. A third were successful, and 15% reported complications requiring treatment. So one way that people can self-manage an abortion is to get pills outside the medical system. So prior to the SHIELD laws, there were organizations like Aid Access that mailed medications from outside the United States. Once SHIELD laws took place, Aid Access, the organization, started sending their pills through physicians doing prescriptions. So they moved into the formal sector. But we know that there are online vendors and just a huge uptick in people trying to get their hands on pills even without any clinician involvement. And I shout out the Massachusetts Medication Abortion Access Project because it's one of them, and it's run by a professor from the University of Ottawa, Angel Foster, not a relative of mine, but somebody who's making a huge difference. So Canadians are helping us in this crisis time. And Las Libres actually is a Mexican organization which is sending pills at no cost to people in the United States. So there have been so many changes post Dobbs that we've actually seen an increase in the number of abortions in the United States once it became illegal in 20-something states. So if we just look at formal sector abortions provided through clinics and telehealth, there's been an increase. And that's due to pills being allowed to be sent in the mail, an increase in the number of clinics and their gestational limits in the protected access states, a huge increase in telehealth, a huge increase in pills sent from online sellers and community groups, and a massive influx of money, kind of like rage donations, people giving money to hotlines and support groups that help people travel for an abortion. So it's really been a huge mustering of efforts to try and get people access to abortion. And so that leads us to the fourth option, which is to carry the pregnancy to term. So the question is, did the increase in abortions post-Dobbs mean that people aren't carrying unwanted pregnancies to term? And my feeling is that this increase is meeting more of the unmet need for abortion in protected access states. It's made it easier to get an abortion across all of the United States. And so this is probably more increase in the protected access states and not reaching every 14-year-old in Louisiana or Alabama that might need an abortion. So there are clearly people who are stymied by laws. And in fact, that probably is disproportionately people with wanted pregnancies who have complications, who are in the hospital and can't just readily get, or who can't readily leave their state. So when I was asked before Dobbs about how many people wouldn't be able to get their abortions, I told reporters a quarter, that I thought a quarter of people who would want an abortion in a state with a ban wouldn't be able to get it. And I based that estimate on many studies of financial barriers. So what these studies where all of a sudden Medicaid does or doesn't cover abortion, what happens to the number of abortions in the state. And then there are other studies of the travel barriers. So if you just remove all the abortion facilities in those states, people have to travel farther. And based on that estimate, Caitlin Myers, a professor in the United States, estimated that a quarter of people wouldn't be able to travel. But in fact, and there have been two published estimates. Dench et al. Estimates that about 23%, so roughly a quarter of those who would have been able to get their abortion without the ban instead carry the pregnancy to term, so estimating 32,000 excess births. And then another one by Bell et al., estimating that 16% of those who would have been able to get an abortion instead carry the pregnancy to term. And both of these studies are studying relative changes in births in banned states compared to protected access states. And there's something wrong with that, which overestimates the effect. So I think that it's much lower than that. So one problem with these studies is that every state was affected by Dobbs and by the FDA decision. So there's no counterfactual of what would have happened if those bans hadn't taken effect. All the improvements in access in protected access states meant that everything changed for all states, both the banned states and the protected access states. Everywhere there was improvement in access to pills online. And we see everywhere we see that overall in the country, the counts of abortions are up. So there are more abortions than before. And if we look at raw data from the Center for Disease Control, which still exists now, and let's hope it continues to exist, we see that both states with bans and without bans showed a decrease in births. But that decrease was greater in states without bans. So there's been no actual raw increase in births. And I have run a study looking at people seeking abortions before and after Dobbs from clinics in banned states and hotlines serving people in banned states. And what we've seen is 3% of people who would have received an abortion instead carried to term. So much smaller than these published estimates. But nevertheless, for anyone who is denied a wanted abortion, there are important outcomes that we should all be concerned about. And these outcomes aren't just important for the people who are banned, who can't get a wanted abortion. They reveal all our weaknesses in how we support low-income families and people who are parenting. So I led a study called the Turnaway study over a period of about 10 years of data collection. And the goal was to look at the mental health, physical health, and socioeconomic consequences of getting an abortion and also carrying an unwanted pregnancy to term. So how we did this study is we recruited people over a 3-year period who were just over the gestational limit of a clinic and just under the gestational limit of a clinic. But these clinic limits varied by site. So you could be denied an abortion at the same exact point in pregnancy if you were recruited in Fargo, that you would have received an abortion if you'd only been recruited in Dallas. So there was a big overlap in gestation. People just over, just under. Most of these clinics had limits in the second trimester, but the vast majority of people, even now, get abortions in the first trimester. So we also included a first trimester sample. We ended up with almost 1,000 women and called them every 6 months for 5 years. And I'm going to use the word women because we incorrectly specified that eligibility was pregnant women, and so no trans men or non-binary people were identified. Here are our sites. Each is the latest gestational limit within 150 miles. And the study design was a success in that people who were just over the limit and just under the limit were very similar at baseline. They had similar mental health history, physical health history, economic status. They differed in parity, the number of children they had, and age, because people who have never given birth before and who are young are slower to recognize pregnancy. And we control for that in all of these analyses. Expected level of participation, you'd be shocked to know that not everyone wants to do a study for 5 years being called every 6 months. It's similar to other longitudinal studies, no difference between those who received or denied abortions, no difference in demographic characteristics. Very high study retention. We lost just about 3 to 5% of people from interview to interview, but because the study is so long, we eventually did lose people. No differential loss to follow-up. And the demographics of the study sample are very similar to people who seek abortions nationally. So, except that we have a larger number of people who were later in pregnancy due to study design. So what are the mental health consequences of receiving or being denied an abortion? What we found is that, and sorry, I've listed just one paper at the bottom for most of these, when there may be many papers on this topic. So I'll also share a annotated bibliography so you can look up lots of papers. But what we see is greater anxiety, lower self-esteem among the people who are denied an abortion compared to receiving one. And at the time of the study, it was really thought that abortion hurts women was the talking point for people who are opposed to abortion. And this clearly shows that's not accurate. In fact, so on the short term, denying people abortions is more harmful. But over time, we actually see mental health of the two groups was very similar, not because both groups were doing badly. In fact, both groups improve over time. Here's just a graph of depression symptoms. You can see improvement over time and very little difference between those who receive and who are denied abortions. Anxiety slightly elevated at the beginning and over time very similar. Just because it doesn't cause a mental health pathology doesn't mean people don't have an emotional reaction to having an abortion. And what we see is that more than 95% of women said that the abortion was the right decision for them. Positive emotions are more common than negative emotions, but still about 40% of people have some negative emotions a week later. But even among the people who have negative emotions, 90% say it was the right decision. So you can feel sad, you can feel guilty or angry and still feel that you made the right decision. This is my favorite graph from the study. This is asking people whether they feel one of 6 emotions, 4 of them negative and 2 of them positive, but we ask them which emotions they're feeling, or are you not feeling these emotions? And positive emotions decrease over time, negative emotions decrease over time. And what happens over time is that people say they're not feeling these emotions. And in fact, they stop thinking about the abortion. And one person said to us, the only time I think about my abortion is when you call me for these interviews. So note also the darker gray is people who feel both very strong positive and strong negative emotions. In terms of people who are denied abortions, at 1 week after being denied an abortion, 2/3 say they still wish they could have had the abortion. It's down to 12% once they've given birth, and 5 years later, it's at 4%. So a side note, very few people decide to place a child for adoption, but it's the people who place a child for adoption who are more likely to tell us that they wish they still could have gotten that abortion. And it makes sense. If you don't have a child on your lap, you're less likely to say that you wish you could have had an abortion. And also, I think that we grossly underestimate the emotional distress that comes from giving birth and placing a child for adoption. I think that's a very hard, I don't just think it, we see the data, it's a very hard emotional experience. So turning our attention to physical health differences, I come from a medical school and this is not the medical language, but continuing pregnancy and delivering a child is a really big deal. And we generally grossly underestimate the physical health sacrifice that people make to become parents. Women are much more likely in our data and in the medical literature to have a life-threatening complication from birth than from abortion. The worst physical health doesn't just end at birth, it lasts for years after delivery. What we see is more hypertension, joint pain, back pain, head pain, and overall worse health. And then the saddest finding of the study is that in this relatively small sample of people who delivered pregnancies that they didn't want, 2 died. So about 1% of people died, which is an astronomical maternal mortality rate. They died of common causes of maternal death, so hypertension and infection. Just showing you some of the physical health data in graphs. So we asked them before they became pregnant to rate their physical health and over time, and you see the blue line, this is people who gave birth, are more likely to report fair or poor health, no difference at baseline, no difference between people who got a first versus a second trimester abortion. If we look at cases of chronic conditions, no differences in most, but differences in gestational hypertension, which they didn't just experience this pregnancy. Many people became pregnant again during the 5-year study. So there was more opportunity for gestational hypertension. And then the top 3 types of chronic pain were statistically significantly different for people who delivered. If we look at, so this slide's going to do a million other outcomes besides physical and mental health that we see differences. So if we compare compared to women who receive an abortion, women who are denied abortions are more likely to live below the federal poverty level, more likely to report that they can't afford basic living needs like food, housing, and transportation. They're more likely to have public records that show they've been evicted, have declared bankruptcy, or have a lot of debt. They're less able to provide financially for their existing children. They're less likely to have an intended pregnancy in the next 5 years. They're equally likely to be in a romantic relationship with the man involved in the pregnancy, but they're less likely to say that their romantic relationship with any partner is very good quality. So seem to be in worse romantic relationships over time. And then at the end of every interview, we ask them their plans for the coming year, and we categorize them later into aspirational or neutral or negative plans. And women who are denied abortions are less likely to set aspirational plans. So showing some of those in graphs, you can see the non-significance difference of economic well-being. So poverty is the same before they were denied an abortion, and over time, those who gave birth are more likely to be below the federal poverty level. This paper, I published this one on self-reported economic well-being, and an economist at the University of Michigan reached out to me and said, what you should do is link your data to credit reports, this objective third party that assesses your financial well-being based on credit cards and public records. And this is her graph. Sarah Miller from the University of Michigan can see this is archived credit data. So you can see that for 3 years before that, these dotted lines reflect the year of the either abortion or delivery. 3 years before that, the 2 groups were the same. They're not the same once the person has delivered. And the green, the people denied abortions, do worse for the next 5 years with no difference, with no convergence. So they're doing poorly over time, more likely to have economic hardship over time than the people who are just under the limit and got their abortion. This is data from the London Measure of Unplanned Pregnancies. It's like 12 items, I think, about how much you wanted to become pregnant. The green is the child born because the mom was denied an abortion, and you can see it's skewed towards less intended. And the blue is the next child born to someone who got an abortion, and those are more likely to be intended. And lots of people who have abortions want more children. They just want them under better circumstances. So this is important to show that, in fact, you may be more able to have a child under better circumstances if you can terminate a pregnancy that isn't under good circumstances. And then one last set of results is looking at violence from the man involved in the pregnancy. What we see is that people who got their abortions had an immediate decrease in physical violence from the man involved in the pregnancy. 1 in 20 reported violence, and 1 in 20 reported violence in the month that they became pregnant. And we see a sharp drop off if the person got the abortion, and no drop off, no increase, but no drop off if they were denied the abortion and carried to term. And that's because they have ongoing contact because they're raising a child together. So even if they're not in a romantic relationship, they have ongoing contact. And then one woman we interviewed who was denied the abortion, and she pretty much summed up these findings all on her own without conducting a whole study. She says, it's very, very difficult to find a job when you're pregnant, to keep a job when you're pregnant, or find and maintain a job with a baby, especially if your partner, here's where she uses a bunch of curse words, doesn't want to help. So domestic violence skyrockets because you're financially dependent on your partner because you have to be home with the kid. Pregnancy is an incredibly scary thing, especially if you cannot trust the person you're with. So to conclude the findings about the Turnaway study, and then I'm gonna one more slide to link it to today's time. The Turnaway study shows the importance of access to abortion on people's physical health, the well-being of their families, the trajectory of their lives. And what we see are that when someone wants an abortion, being able to get an abortion is associated with better physical health, economic security, setting of aspirational plans, ability to take care of their existing children and their future children. I wrote a book which has like the story of the science. How did we do the study? What did we find? But also 10 women that we interviewed of 25 to tell their stories in their own words in full. So the book is worth it for the stories alone. Here's where you can find a link to the bibliography of our scientific papers. We wrote 50 plus scientific papers. There's where you can find the book. And then my sister wrote a play. This book came out in 2020. I thought I was going to go on a book tour. I wanted the voices of women to come with me on the book tour. So I asked my theater involved sister to like write a treatment so that I could hire local actors and have those voices with me. And when the pandemic hit and there's no book tour, she turned it into a whole play. So it's available for anyone who wants to use it for education or to raise money for good causes. So feel free to check that out. So what's happening now in the United States is that this crazy new administration really, at least originally, seemed to be threatening to restrict access to medication abortion. One way they could do it is prohibit mailing of medication abortion pills. And there's a existing law from like the 1800s called the Comstock Law that, was aimed to not let anyone have access to contraceptive information or pornography or something. And so saying that this is related would be one way of stopping people from sending pills. There's efforts to roll back the FDA decision that allowed pills to be sent in the mail. That case is already at the Supreme Court, and they may hear it again now that the election's done and they don't have to worry about political blowback. And then there's efforts to undermine these laws that protect physicians in protected access states and allow them to prescribe to send pills to people in banned states. Those are called the shield laws. And there's already a case, Louisiana, pressing charges against a provider from New York. And then to stop people from traveling, there's attempts to criminalize the support people and organizations through trafficking laws that somehow abortion trafficking. And so what is at stake if abortion services and pills were no longer available? The least advantaged people would likely be the ones to carry pregnancies to term, and this would cause serious physical health risks, both from unsafe abortion attempts if people can't access medication abortions, which are very safe, and also physical health risks from carrying an unwanted pregnancy to term. We have very high maternal mortality compared to Canada, and even in Canada, it's everywhere. Ending a pregnancy is safer than carrying it to term because you're pregnant for less time and because delivery is a big deal. And so this would have physical health risk. Very few people place their children for adoption, and I think that the the suggestion that that's an easy solution is wrong. When people are unable to get an abortion, if they carry the pregnancy to term, they're less likely to have wanted kids later, either because they have all the children they can support, or because those better circumstances that they were hoping for, the better relationship, the more steady job, the financial security that they wanted, the circumstances they wanted to have kids under, those don't emerge because they're trying to raise a child that they weren't ready for. And so related, those who are unable to get abortions will experience economic hardship and curtailed life ambitions. And this will not just affect the pregnant person and women, it'll affect children. It will mean more children raised in poverty and strain. Please ask any questions. Dr. Racine offered to translate if you ask me in French, because my French is terrible. You also can ask via, I think, the Q&A feature. Thank you so much.
Thank you. Thank you so much for sharing this really important research that is so informative and important for our policies. So now we have time for Q&A. So the way we like to do this is ideally for you to write up your question in French or in English in the Q&A tool. I will read it out loud and Dr. Foster will answer your question and we will move along and
Or
address.
dodge it.
Oh, dodge it? We will try to get to as many questions as we can. There are a lot of people, but we are encouraging you to formulate those questions. There's already one formulated in the Q&A. Question is there not any law currently in place in the US to protect the pharmaceutical sector for continued manufacturing of abortion drugs from women with unwanted pregnancy? So is that in place?
That's a really great question and not one that I have a lot of expertise in. My impression is that first of all, if you order pills online, they're not being manufactured by any formal company. There are generics made by the informal sector in India and Russia, in various places. So those the drugs will still be manufactured even if they're made illegal. Right now, our government isn't at all sympathetic to the few companies that officially make mifepristone, so I'm sure they won't be trying to protect those companies.
Thank you. A second question from Dr. Nicole Palmer. Hi, Nicole. She's alumni from our group. If we have the right or the exact Nicole Palmer I'm thinking of, and she's asking, have you looked at the commensurate changes in contraception? Has there been a change since Roe was overturned?
This is a really good question. First, some background is that 2/3 of the people in my study were using contraception in the month they conceived. So just use of contraception does not necessarily prevent the need for abortion, both because there are wanted pregnancies that end in abortion and also because contraceptives are so widely used and not perfectly effective. So if you have a lot of people using something that isn't perfectly effective, you get people who are pregnant when they aren't ready. I know that there was a lot of hype that there would be this big increase in IUD use, for example, or implant use. I don't think it's been big, in part because people rarely think that they're at risk of an abortion. Like, people don't, yes, there are the worried well who do everything they can to prevent pregnancy, but though they were already using contraception. And there are people who feel like life happens and contraceptives are unpleasant and difficult to access. And I really doubt that they heard the news that abortion is more difficult to get now and are deciding to adopt. So at best, I would guess that there's people moving from less effective methods to more effective methods, but even though I know this is a hope, I would be very skeptical. I'm very surprised if this is a big effect.
Thank you. Next, we have two questions from a colleague from University of Montreal, Dr. Isabelle Bouquaran. She's a OBGYN FMM specialist. She's asking first about access to pregnancy termination for congenital anomalies or maternal health reasons. Can you share a bit
Yeah,
on that?
so it depends on the state whether abortion is available for in cases where the woman's health is at risk or the woman's life is at risk. Everywhere where there's imminent death, the person can access abortion, but not health. Whether there's an exception for people who are extremely sick, it varies by state. And often what the effect of that is someone comes to the emergency room or emergency department with a pregnancy complication and has to wait until their life is at risk until they'll be helped, which is insane. Not standard of care for medicine. I don't need to tell this questioner. And so I have a study now, but I don't have results yet of what emergency departments are doing for people who have maternal health indications and how this law has affected. I do know that physicians are really dedicated to not letting their patients die and not putting their patients at risk, and they try very hard to facilitate care. And congenital anomalies, sometimes these are explicitly banned that you should get an abortion for a congenital anomaly. Down syndrome is the most common of saying that's explicitly banned. You cannot have an abortion if your reason is a fetal diagnosis of Down syndrome. So I don't know. I think it is people who are late in pregnancy who have diagnoses who are probably most affected by these bans.
And Dr. Bouquaran has a second question, which was also on my mind. It's the following. Have you heard about U.S. women coming to Canada for abortion services?
I have not heard, but I'm not sure I would have heard. One is that it's rarely, except for Idaho, it's not states very close to Canada that have the bans. Good abortion laws seem to be high up north and get worse as you go south. So it's your borders, they can hit a lot of US states where it's possible to get an abortion before they would hit Canada. Canada has better laws than most US states. There are very few states with laws as good as Canada. And so I think it's possible that people with very late pregnancies with severe complications may go to Canada. But otherwise, you can hit a legal abortion provider before you get all the way to Canada. And lots of people don't have passports. They don't. So crossing national borders is really not easy for a lot of people.
Thank you for your questions. Also in your answers, we have another question now from Julie Archambault. She's asking, have we compared similar data before Roe, if we have some and after Roe cancellation?
Yeah, so the interesting thing is that this whole Turnaway study that I did was done before, oh, I'm sorry, you're saying before Roe, not before Dobbs. Anyway, so sorry, I'll finish my thought, but it's not going to help you. It was done before Dobbs. So all of the people who couldn't get abortions in the Turnaway study, they were affected by, abortion was not easy to access even before Roe was ended. But that wasn't what you were asking. You were saying before Roe even started. The whole industry of social science doing this, I think, was not as developed before 1973. So I don't know of studies like this before Roe, before 1973. I do know that there was a lot of travel in the year. There was a period of years where it was legal in just a few states, and it was clear there was vast amounts of travel in those years to New York and some other states. And then there was a really more similar to my study was a study of people in the Czech republic, then Czechoslovakia, in 1962. Women who, if you wanted an abortion then, you had to go before a hospital committee and seek an abortion from this committee. And so a group of scientists looked at what happens to the kids born when their mom was denied by those hospital committees and compared them to kids born at the same hospital, I think roughly the same family structure, matched by family structure maybe. And this book was written by Henry David and called Born Unwanted. And because it's the Czech Republic, they had incredible data, so they could follow kids over time using identification numbers. They could see incarceration rates, mental health, institutionalization, all sorts of things. And the net effect of that study was that it was just focused on the children, not on the pregnant women, and that boys especially had worse outcomes when they were born of a pregnancy that wasn't wanted. And I would dispute the whole word born unwanted, because most of the people in my study came to accept the kid by the time they were born. So I don't like the idea that the kid is born unwanted. The pregnancy was clearly unwanted. And it's hard. And we did study maternal bonding with those kids. And, people are more likely to report poor bonding with the child born when their mom was denied an abortion than the next child born to someone who got an abortion. So it does, having this strain either of relationships or finances is really hard. And to some degree, it affects your bond with your children.
This answer relates a bit to the next anonymous question. Do you know anything about studies related to kids' happiness from the ones born from undesired pregnancy or refused abortion compared to kids overall?
So I'm glad. So the only things I know are from the mom's perspective of reporting maternal bonding, and this Czech study that focused entirely on kids. I don't think happiness was in the Czech records, so it's not happiness per se, but mental health challenges for sure. That's the best I've got. And I do want to say, in our long human history, all of, our ancestors weren't able to plan every pregnancy. This is common to have a pregnancy that you weren't ready for and that aren't ideal circumstances. And it's not always bad under every circumstances. It's just people are extremely resilient and it's hard. And the outcomes aren't as good if people have control their outcomes and their kids' outcomes are better. But it doesn't mean that people are doomed if life throws them some curveballs.
So next we have a question from a colleague based in Halifax, Nova Scotia, Dr. Marika Warren. She's a bioethicist. She's asking, thank you so much. Well, she's saying thank you so much for this presentation and your work. And she's asking, I'm curious about legal professional protection for providers who are continuing to provide abortion care. Are there efforts to undermine access by reducing recourse for providers whose practices are challenged?
Definitely that this is a strategy it's always been the strategy of the anti-abortion is to focus much more on the provider than on the pregnant person, which is interesting because now things have shifted so that people are, taking pills on their own. So it's going to make it very hard for them to prosecute a provider in that case. But there is this case in Louisiana where they're trying to bring suit against a prescriber, a doctor in New York. So I don't know all of the legal support systems available to those doctors, but definitely there's a lot of effort to support them. And I don't know, it's just so hard to know what's happening in my country, whether that support will be enough or not.
I guess it's time to come to a close to this conference. And again, we want to thank you so much. Benedict can't be with me to thank you. She really helped organize your lecture today, as well as Isadora Foster. And we're very grateful for the time you dedicated to this presentation, your preparation, and your willingness to exchange with us and answer so many questions, although there are more coming and more coming. But I think that's a good sign that people were engaged with the lecture and the content. And what I'm going to do is simply announce the next conference. Donc, la prochaine conférence va prendre la forme d'un panel en ligne qui aura lieu le 10 avril. Et les conférencières sont Dr. Sylvie Lévesque de l'UQAM et Dr. Suzy Basile de l'Université du Québec au Témiscamingue. Et la thématique du panel va être les violences obstétricales et gynécologiques. Et individuellement et ensemble, Dr. Lévesque, Dr. Basile ont ou sont des pionnières dans la recherche dans ce domaine, notamment en ce qui concerne les violences qui sont faites aux femmes autochtones. Donc, on rappelle aussi le sondage que vous pouvez compléter pour contribuer au développement de pistes d'action et de réflexion sur la santé et le bien-être des femmes cette année. So again, thank you so
Thank you.
much. And we hope to hear more about your work and would have loved also to hear more about your experience doing this research. I'm sure these are difficult times, and I think all of us are encouraging the friendships
Yes.
you were alluding to, as well as continued collaborations.
Yes. Thank you so much. It's great to spend a little lovely time with this group of Canadians. Thank you.
Thank you so much. Bon après-midi tout le monde.